So the top 10 lung cancer articles that I'll go over today will be some of the screening, the NLST and the Nelson, the surgical curative study CheckMate, the curative package sandwich immunotherapy Keynote 671, AEGEAN, and then we'll go over the NeoADAURA trial, and then the stage 3 unresectable Pacific and LAURA trials. Then we'll go over metastatic non-small cell lung cancer immunotherapy, Keynote 189, Keynote 024, and then the FLORA and FLORA-2 trials for EGFR metastatic disease, and then lorlatinib, the ALK positive non-small cell lung cancer, and then the small cell lung cancer, tarlatamab, and then some of the testing, Delphi and Signatera. And that's what we'll do. We'll start with the pre-diagnosis setting, screening, NLST, New England Journal of Medicine 2011, and the Nelson, New England Journal of Medicine 2020, looking at low-dose CT versus chest X-ray in high-risk smokers. That was the NLST, decreased lung cancer mortality by about 20%. The Nelson trial, low-dose CT versus no screening, decreased mortality more in women than in men, but it's classic. It's the only intervention proven to reduce lung cancer mortality. Then we have the first study that we'll talk about, CheckMate 816. CheckMate 816, we're talking about patients that are going to have resection for lung cancer. Should you treat them initially with immunotherapy to sort of downgrade the tumor? So nivolumab plus chemo versus chemo, pathologic complete response, 24% versus 2%. This is the first proof that immunotherapy improves surgical pathology. This is when neoadjuvant immunotherapy becomes standard, New England Journal of Medicine 2022. The next two studies together, Keynote 671, New England Journal of Medicine 2023, and AEGEAN. So now we're talking about sandwich immunotherapy. So basically you're going to be doing neoadjuvant immunotherapy, priming the immune response while the tumor antigen is present, surgery, which will remove the bulk disease. And then after the disease is removed, you do adjuvant immunotherapy, and it suppresses the residual microscopic disease. So pembrolizumab was used in the Keynote, and durvalumab was used in the AEGEAN study. So it's chemo plus PD-1, or in the AEGEAN case, it was PD-L1, perioperative versus chemotherapy, and it improved the pathologic complete response. And so this integrates pre and post-op immunotherapy into the single curative strategy, so-called sandwich immunotherapy. So like the Keynote and AEGEAN is this NeoADAURA. It's not yet published per se, but it's presented at ASCO 2025, looking at EGFR resectable disease. So osimertinib plus or minus chemo versus chemo. Again, looking at major pathologic response. It's not a sandwich, like sandwich immunotherapy type of thing, where you don't give it before and after. It's talking about before. And the major pathologic response was 25% versus 2%. This is the first strong EGFR neoadjuvant success. So now we're looking at stage 3 unresectable, locally advanced CRT, consolidation, curative. Consolidation is split. So specific trial looked at durvalumab, and LAURA trial looked at osimertinib. So immunotherapy in the specific trial in patients that don't have a target. So that seemed to be better. Overall survival 47 versus 30 months. The LAURA trial specifically looked at osimertinib, so positive EGFR patients, showed a very significant progression-free survival, 39 months versus 5.6 months. This is a massive effect size, one of the biggest in thoracic oncology. Stage 3 is now biologically split immunotherapy versus EGFR consolidation speaking, and that would be for stage 3 unresectable disease. When it comes to metastatic non-small cell lung cancer, as opposed to locally advanced stage 3 tumors, we have Keynote 189 and Keynote 024 and CheckMate 017057. So the Keynote 189 looked at chemo and pembrolizumab. The immunotherapy showed an overall survival 22 versus 10.7 months. Keynote 024, specifically PD-L1 greater than 50%. So Keynote 189 looked at all comers, and that Keynote 024, specifically PD-L1 greater than 50%, showed overall survival double with the pembrolizumab. The older CheckMate 017057 showed immunotherapy better than docetaxel. So immunotherapy replaces chemo across metastatic non-small cell lung cancer, regardless of the PD-L1 levels. Okay, so what about the metastatic disease, the subgroup of EGFR positive? So for that, we have FLORA and FLORA-2. So osimertinib in the FLORA trial was defined best upfront EGFR therapy. It replaced earlier TKIs, 39 versus 32 months. But the FLORA-2 trial looked at osimertinib plus chemo, and the hazard ratio of 0.62. So 40% did better with the osimertinib plus chemo. So shift the EGFR for monotherapy. So not only is there a better one, osimertinib, but it's also now combined with chemotherapy, FLORA-2 trial. And then the ALK positive group, non-small cell lung cancer, crowned the lorlatinib versus crizotinib, with the progression-free survival not reached, meaning the midpoint was not even met by the time they got the data. So it was like really good versus 10 to 12 months of crizotinib, near complete CNS control. So now ALK becomes CNS protected systemic disease. With the lorlatinib, brain mets prevention is a core endpoint. So that is good news there. And then the first targeted immunotherapy signal in small cell lung cancer in the tarlatinib trial, DLL3-BITE versus chemo, overall survival plus durable response improvement in relapsed small cell lung cancer. This is small cell lung cancer that has been treated with chemotherapy first. This is the first biologically targeted survival signal in small cell, and it breaks the pure chemotherapy paradigm. And the last lung cancer articles to discuss or concepts is the Delphi and Signatera. So the Delphi assay, it's blood-based DNA fragmentation screening. It's an adjunct to low-dose CT. And the Signatera is really post-curative therapy. So the Delphi looked proof of concept lung screening cohort, CHEST 2023, Nature 2019. Large multi-cancer validation showed 73 to 80% sensitivity with high specificity. And the Signatera showed ctDNA positive that strongly predicts recurrence and precedes radiographic relapse by months. So it's shifting oncology from image-only paradigm, molecular continuum spanning early detection, Delphi fragmentomics, and post-treatment relapse surveillance with ctDNA. So to summarize, we have the top 10 articles screening NLST and Nelson showing roughly 20 to 30% improvement in lung cancer mortality. Then we looked at early stage resectable non-small cell lung cancer, nivolumab, neoadjuvant immunotherapy becomes the standard. Then we looked at the sandwich immunotherapy, the Keynote 671 AEGEAN, which looked at both pembrolizumab and durvalumab as the sandwich IO therapy. But then in the EGFR subgroup, we looked at NeoADAURA, which is osimertinib plus chemo versus chemo. And that was not a sandwich therapy. That's before surgery. Then we looked at stage 3 non-resectable locally advanced CRT. We saw that they were biologically split. So if you have no targets, then you give durvalumab or immunotherapy. That is the Pacific trial. And if you have targets, then you use Laura's osimertinib. And then we went over metastatic non-small cell lung cancer, looking then at Keynote 189 and Keynote 024. The Keynote 189 had no difference in the PD-L1, and you would just give immunotherapy, whereas the PD-L1 was greater than 50%, you would give specific immunotherapy. And it seemed to replace chemo across all metastatic non-small cell lung cancer, regardless of PD-L1. And then we went over FLORA and FLORA-2 trials. The FLORA basically showed that osimertinib is the best one for the metastatic EGFR, and then you add it with chemo up front, and it gives you the highest progression-free survival. Then we went over lorlatinib, ALK positive, really showed near complete CNS control. And then small cell lung cancer, the new tarlatinib trial, first time, it's just not just chemotherapy anymore. So we have immunotherapy for small cell lung cancer as well. And that's the story.